Okay, guys, so we're going to talk about the respiratory system, another very important system in our bodies. The respiratory system is actually broken down into two parts because, of course, we don't want to make this easy for you. The upper respiratory tract and the lower respiratory tract. The upper one has all those structures that are outside of the thoracic cavity. So that includes the nose, the nasopharynx, the oropharynx, the laryngopharynx, and the larynx. These structures work to warm and humidify air that you breathe in or humidify inspired air. They're also responsible for the senses of smell and taste, as well as chewing and swallowing. The lower respiratory tract, those are the things inside the thoracic cavity. That's the trachea, the bronchi, and the lungs. The nose and the nasal cavities, air enters and leaves the respiratory system through the nose most of the time under normal circumstances. Just inside the nostrils are small little hairs called cilia. These cilia filter out dust and large foreign particles. The nasal cavity is separated from the mouth by a bony structure called the palate, and then a vertical plate of bone and cartilage called the septum is what separates the nasal cavity into two halves. The cavity is lined with epithelium that's rich in goblet cells, and those goblet cells produce mucus. Projecting from the lateral wall of each cavity are three bones called conchi. The conchi warm and moisten the air as it flows past. At the same time, dust sticks to the mucus, which is then swallowed. Branches of the olfactory nerve, which is responsible for the sense of smell, penetrate the upper nasal cavity and lead to the brain. Then the sphenoid sinus, which you can see right here, and other paranasal sinuses, including the frontal, the maxillary, and the ethmoidal sinuses, drain mucus into the nasal cavity. The pharynx, just behind the nasal and the oral cavities, is a muscular tube called the pharynx. It's commonly called the throat. And the pharynx has three regions. The nasopharynx, just behind the soft palate, that contains the openings for the right and left eustachian tubes. I think we talked about those when we did the senses, and how that's part of how the ears maintain release pressure. The oropharynx is a space between the soft palate and the base of the tongue. That's where your tonsils are. The palatine tonsils specifically, those are the ones most commonly removed when you have your tonsils out or tonsillectomy. And then the lingual tonsils, which are found at the base of the tongue. The laryngopharynx passes dorsal to the larynx and connects to the esophagus. The nasopharynx only has air passing through it, whereas food and air both go through the oropharynx and the laryngopharynx. The larynx prevents food and liquids from entering the trachea. It acts as an air passageway between the pharynx and the trachea, and it's what produces sound. It's your voice box. It's formed by 9 pieces of cartilage that keep it from collapsing, and there's a group of ligaments that bind the pieces of cartilage together and to the adjacent structures. The epiglottis, which closes over the top of the larynx when you swallow, in that way the food is directed into your esophagus, not into your trachea, is the uppermost cartilage. The largest piece of cartilage is the thyroid cartilage, also known as the Adam's apple. The mucous membrane lining the larynx forms 2 pairs of folds. The superior pair, called the vestibular folds, close the glottis, the opening between the vocal cords, during swallowing to keep food and liquids out of the airway. They play no role in speech. The inferior pair, the vocal cords, produce sound when air passes over them, and the opening between the cords is called the glottis. The lower respiratory tract, I said a few minutes ago, consists of the trachea, the bronchi, and the trachea lies in front of the esophagus. It's a rigid tube. It's about 4.5 inches long and about 1 inch wide. There are C-shaped rings of cartilage that encircle the trachea to reinforce it and keep it from collapsing. The open part of the C faces posteriorly, so it faces towards the back, which gives the esophagus room to expand during swallowing. At the carina, and the carina is right here, that's where the trachea branches into 2 primary bronchi, one primary here, one primary here, one for each lung, right and left. These also have C-shaped rings of cartilage. The right bronchus is slightly wider and more vertical. So this is really, if you aspirate food, get it into your windpipe by mistake and aspirate it, is the most likely spot for the food to get stuck or lodged. And here they have the primary bronchi shaded in green for you. Right after the bronchi enter the lungs, the primary bronchi branch into secondary, one for each of the lungs lobes. So the left lung has 2 lobes, the right one has 3. So there's 2 secondary bronchus in the left lung and 3 of them on the right. And you can see them on this picture. They colored them yellow for you. Wasn't it nice to make it color-coded like that? The secondary bronchi then branch into smaller tertiary bronchi. These are the ones shown in orange. The rings around these bronchi become irregular and then they disappear in the smaller bronchioles. The tertiary bronchi continue to branch, resulting in very small airways called bronchioles. These are the ones in purple. Bronchioles then divide further to form thin-walled passages called alveolar ducts. The alveolar ducts throughout the lungs end in clusters of alveoli called alveolar sacs. These are the primary structures for gas exchange. The alveoli, the lung passages all exist. All roads lead to the alveoli, so to speak. It's within the alveoli that gas exchange occurs. So the alveoli are really the functional unit of your lungs, like the nephrons are the functional units of your nervous system. Kidneys. And the neurons are the functional unit of your nervous system. The alveoli are wrapped in a fine mesh of capillaries. There's extremely thin walls of these alveoli, and the capillaries are so close, this allows for the efficient gas exchange. This gas exchange occurs through the respiratory membrane. This membrane consists of alveolar epithelium, the capillary endothelium, and then their joined basement membranes. The inside of each alveolus is coated with a thin layer of fluid containing surfactant. The surfactant is a substance that helps reduce the surface tension, in other words, the force of attraction between water molecules. And this is what keeps the alveolus from collapsing as air moves in and out during respiration. The lungs fill the pleural cavity. The primary bronchi and pulmonary blood vessels enter each lung through a slit on the lung's medial surface called the hilum. If you remember, we heard the word hilum when we looked at the kidneys. Just like in the kidneys, the blood vessels and nerves go in and out of the kidneys through the hilum. The bronchus and the pulmonary blood vessels go in and out of the lungs through the hilum. The top of the lungs, or the apex of each lung, extends about 1/2 inch above the first rib, and the base of each lung rests on the diaphragm. And in this case, the base is the bottom. Like with the heart, you remember the base was actually at the top because it was the widest part. In this case, the base right here is the widest part of the lung. It rests right on the diaphragm. The apex is the top. It's the narrow end of it. The right lung is shorter, it's broader, it's larger than the left. It's got 3 lobes, and it handles about 55% of the gas exchange. There are 2 fissures on the right lung that separate the 3 lobes, the horizontal and the oblique. The horizontal kind of looks like it's horizontal, and the oblique has a little bit more of a slant to it, so it goes kind of in an oblique angle. That's why they call them those things. The left lung only has 2 lobes, the superior and inferior lobe, and it only contains 1 fissure, the oblique fissure, right here. And again, it's kind of in an angle, that's why we call it the oblique. The pleura. The pleura is a serous membrane. It's actually called the visceral pleura. It's shown in blue here in the picture, right here. That covers the surface of the lungs, and it extends into those fissures. So you can see, like right here is one of the fissures, and the pleura extends into that, going around and lining it. The parietal pleura, that's shown in green in this picture around the outside, lines the entire thoracic cavity. There's a space between these two, the visceral and the parietal pleura. It's shown in orange here. This is called the pleural cavity. It's actually a potential space. These 2 membranes are normally separated only by a little teeny bit of slippery pleural fluid. This fluid lubricates the surfaces, allows the 2 of them to glide back and forth against each other as the lungs expand and contract. And also because the pressure in the pleural cavity is lower than the atmospheric pressure, it creates a pressure gradient that helps to keep your lungs inflated. So pulmonary ventilation, it's the inspiration and expiration. So it's really one breath in, one breath out. Depends on your respiratory muscles, and it also depends on the difference between air pressure inside your lungs and outside them. The main muscle that's responsible for pulmonary ventilation is the diaphragm. During inspiration, when you breathe in, the external intercostal muscles pull the ribs up and out, which widens the thoracic cavity. The internal intercostals help elevate the ribs, and then the diaphragm contracts, it flattens, and it drops down. And it presses the abdominal organs downward, which enlarges the thoracic cavity. Then the pressure inside your lungs is lower than the pressure outside, and air rushes in order to equalize that pressure. When you breathe out, the internal intercostal muscles relax. The diaphragm relaxes, moves back upward, and presses against the base of the lungs. This reduces the size of the thoracic cavity, so then air pressure is higher inside your lungs than outside, and air is pushed out. During times of forced or labored breathing, you can use accessory muscles of respiration to help with your breathing. The muscles of the neck, like the sternocleidomastoids and the scalenes, and then the chest, the pectoralis minor, contract to help elevate the chest. During forced expiration, you see this a lot with kids, the rectus abdominis and the external abdominal obliques contract down. They contract to pull down the ribs in the sternum, which further reduces chest size and pushes air out more rapidly. The neural control of breathing. Muscles used for breathing are skeletal muscles, and they require nervous stimulation to contract. Unconscious breathing resides in the medulla and the pons, part of the brainstem. The medulla contains two interconnected centers that control breathing, the inspiratory center and the expiratory center. The inspiratory center in the medulla is the primary respiratory center. It controls inspiration and then indirectly expiration. The inspiratory center sends impulses to the intercostal muscles and to the diaphragm. The inspiratory muscles contract, causing inhalation. Nerve output then ceases abruptly, causing the inspiratory muscles to relax. The elastic recoil of the thoracic cage produces exhalation. In the pons, the apneustic and pneumotaxic centers are there. These influence the basic breathing rhythm. And the expiratory center sends impulses to the abdominal and the accessory muscles. So factors that influence your breathing: oxygen levels. Sensory receptors throughout the body signal respiratory centers about the body's needs. There's peripheral chemoreceptors in the carotid and the aortic bodies that detect low blood levels of oxygen, and they send the signal to the medulla to increase the rate and the depth of respirations to bring in more oxygen. Chemoreceptors, central chemoreceptors, specifically in the brainstem, detect decreasing pH levels and signal the respiratory centers to increase the rate and depth of breathing to blow off excess carbon dioxide and increase the pH. So if you get acidic, if your pH level drops too far, those receptors are going to kick in, make you breathe faster and deeper so you can blow off more and get your pH back up into its normal range. Receptors in the lungs and the chest wall detect stretching and signal the respiratory centers to exhale. And the hypothalamus and the limbic systems alter breathing in response to emotions, like when you start crying. Nerve cells and airways respond to irritants by signaling muscles to contract, causing a cough or a sneeze. So atmospheric pressure is what drives respirations. When the pressure within the lungs drops lower than the atmospheric pressure, air flows in. So when your muscles contract, your diaphragm drops down, so the size of your thoracic cavity enlarges and the pressure is lower. The pressure inside your lungs is lower, air is going to flow in. When those muscles relax, your diaphragm goes back up, makes your thoracic cavity a little smaller, the pressure goes higher, and then air flows out. And I think I'm going to go through this one more time, kind of quick. The respiratory cycle, the intercostal muscles contract, pull the ribs up and out. The diaphragm contracts and moves downward. This enlarges the chest cavity. The lungs expand along with the chest because the two layers of the pleura. The parietal pleura is attached to the ribs. The visceral pleura covers the lungs. A thin film of fluid between these two helps them to stick together like two pieces of wet paper. The potential space between the two maintains a pressure slightly less than the atmospheric pressure. This is called the intrapleural pressure. These words are hard to say. When the ribs expand and the parietal pleura pulls away, the intrapleural pressure becomes even more negative. This is kind of like a suction-like effect, causing the visceral pleura to cling even tighter to the parietal pleura. The visceral pleura follows the parietal pleura, pulling the lung along with it. When the lungs expand, the volume of air in the lungs spreads throughout the enlarging space. This causes the pressure within the bronchi and alveoli to drop. The pressure in the bronchi and alveoli is called the intrapulmonic pressure. When the intrapulmonic pressure drops lower than the atmospheric pressure, air is going to flow in down the pressure gradient. Normal expiration is passive. The diaphragm and the intercostal muscles relax. The thoracic cage springs back to its original size. The lungs are compressed. The intrapulmonary pressure rises, and then air flows down the pressure gradient and out of the lungs. Things that can affect the airflow: pulmonary compliance and the alveoli surface tension. With pulmonary compliance, this refers to like the elasticity of the lung tissue, how easily it can stretch and relax. Ventilation cannot occur if the lungs and the thorax don't stretch and recoil. Some things that can cause the problems with this and making the lungs less elastic are like tuberculosis, black lung disease, emphysema is another one, because your lungs lose that elasticity. They can't contract back as well. There's not as much air leaving, so there's not as much room for air to come in. Alveolar surface tension. The inner surface of each alveoli is covered with a thin film of water. This is necessary for gas exchange. However, water molecules are attracted to each other, so left by themselves, they're going to move toward each other and collapse the alveoli. If your alveoli collapse, gas exchange cannot occur, obviously. So to avoid this problem, the alveolar cells secrete surfactant. This is a lipoprotein. It disrupts the electrical attraction between the water molecules, which lowers the surface tension and prevents the collapse of the alveoli. A couple terms to know about measurements of ventilation. Tidal volume. This is the amount of air inhaled and exhaled during quiet breathing. So during normal breathing, tidal volume is the amount of air you breathe in and out. The inspiratory reserve volume, this is the amount of air inhaled using maximum effort after a normal inspiration. The expiratory reserve volume, this is the amount of air that can be exhaled after a normal expiration by using maximum effort. If you've ever had a pulmonary function test, you're doing a lot of these kind of things. Residual volume, the air, and it's about 1,300 mLs, that remains in the lungs after a forced expiration. This air ensures that gas exchange continues even between breaths. Vital capacity is the amount of air that can be inhaled and exhaled with the deepest possible breath. So this is the tidal volume combined with the inspiratory and expiratory reserve volumes. And then total lung capacity is the maximum amount of air that the lungs can contain. This is the vital capacity plus the residual volume. So gas exchange depends on differences in pressure, and gas will go from higher to lower pressure until the pressures are equalized. So the contribution of a single gas in a mixture of gases is called partial pressure. I'm not going to expect you to know all the numbers that go along with this. Do know that you want a higher partial pressure of O2 than CO2 in your blood. That's something that's tested with blood gases when they do arterial blood gases. It's probably also part of a pulmonary function test. The partial pressures of oxygen and CO2 or carbon dioxide are going to vary between the air we breathe, the alveoli, our arterial blood, and venous blood. It's these variations that allow the body to absorb oxygen and expel carbon dioxide. Of the oxygen entering the body, only about 1.5% is dissolved in blood plasma. The remaining 98.5% of oxygen travels to the lungs, where it forms a weak bond with the iron portion of hemoglobin to form oxyhemoglobin. And I think we talked about this when we talked about blood. Oxyhemoglobin travels to the cells. The difference between venous and arterial pH breaks that bond, and then oxygen is released to the tissues. And then the last thing we're going to talk about is the transport of carbon dioxide. Carbon dioxide binds to hemoglobin to form carbaminohemoglobin. That's not even up there. So carbaminohemoglobin. Hemoglobin can transport both oxygen and CO2 at the same time because remember they bind to different parts of the hemoglobin molecule. The oxygen combines with the heme and the CO2 combines with the globin. Most of the carbon dioxide in your body is carried in the form of bicarbonate ions. Good thing this is almost done. This occurs because when the carbon dioxide dissolves in plasma, it reacts with the water in the plasma to form carbonic acid. Carbonic acid then dissociates into bicarbonate and hydrogen ions. If you remember when we did the acid-base balance with the renal system, the equation I showed you, that's a constant back and forth to maintain your pH. So we've talked about the different parts of the respiratory system, the functional parts, how air enters, what a respiratory cycle is and how that happens, the differences between pressure to get air into your lungs and out of your lungs, and then the transport of oxygen and carbon dioxide.